Welcome everybody to our first virtual prostate cancer research tour. We are super excited to have all of you joining us this evening. My name is Pam Taylor, and I am the Director of Development at London Health Sciences Foundation. And together with my colleagues and the clinician researchers joining us this evening, we're super excited to have you here. Thank you for taking the time to be a part of this. It does promise to be a super interesting couple of hours. A few things before we get started. I just want to let everybody know that you all are currently muted, and that is to help protect with the sound during the presentations. We are recording this evening, so if you are not comfortable with that, please do feel free to go to your camera, turn your camera off, and there won't be any visual. Today's tour presentation is divided into 4 different sections. At the end of each one, there will be an opportunity for you to ask questions. That can be done by looking at the bottom of your screen, and you'll either see a participant or a reactions tab. When you click on that, your hand will raise. That's a signal to us that you've got a question. We'll go ahead and call on you for the answers. And again, before we begin, just want to thank everybody so much for taking the time to join us, being interested in the incredible prostate cancer research work that's happening here locally, and also for being donors. Donors make all the difference to this work. So a huge thank you. And without further ado, we'll go ahead and get started. First up, we have Dr. Glenn Bauman and Dr. Erin Ward. And Dr. Glenn Bauman is a professor in the Division of Radiation Oncology, Department of Oncology, specializing in the treatment of central nervous system and genitourinary cancers. He has research interests in cancer imaging and precision radiotherapy applied to the treatment of men with prostate cancer. Dr. Erin Ward is a principal investigator in the Baines Imaging Research Laboratory, located in the Gerald C. Baines Center for Translational Cancer Research at the London Regional Cancer Program. He is an associate professor in medical biophysics, biomedical engineering, and oncology at Western University. Dr. Bauman, Dr. Ward, over to you.
Okay, so I hope people can see my screen. Do you see the first slide? And Pam's nodding, so that's good. So thanks very much for spending some time with us. It's always a privilege and a pleasure to share the work we're doing, and we find it exciting and we're passionate about it, and we always enjoy talking about it and getting other people excited about it. So thanks for your interest. And so I'm going to give a little bit of the clinical perspective, and then Dr. Ward is going to dive a bit deeper into some of the cool stuff that's being done in our little corner of prostate cancer research. So I mean, really what we're focused on in our research, but also I think, a broader effort citywide is really looking at this idea of advanced imaging applied to prostate cancer, so we can detect cancers sooner, understand how aggressive they are, and design treatments for men with prostate cancer better. And so what we've done over the years, and it's kind of sort of sobering to think that this has been underway for quite some time, but basically based on seed funding through the foundation, we were fortunate to get the pieces in place to become successful with securing a large CIHR grant to really help us explore this question of, when we get a scan of a man with prostate cancer, what really is going on in the prostate underlying those images that we're seeing? And can those images be used to their maximum benefit to help us understand where the cancer is, how aggressive it is, and then know how best to treat it? So this, we call it a pipeline of research, basically is what it's really trying to do is really marry the information that we know is in the tissue. So this is a tissue section from a prostate after it's been removed from the body. This is an image of the prostate when it's still in the body. So understanding the relationship between the changes we see here with what's going on in the tissue could really help us, because then we could make advanced decisions based on the imaging as to which men might be treated best with what modalities and such. So our pipeline of research has really been built on a series of clinical studies where we've been fortunate to have men who have really volunteered their time and agreed to go on to these studies and have imaging before they have surgery. So these are men who have chosen to have a prostate surgery to remove the prostate, and then they have allowed us to take images before surgery. And then we have developed techniques, which Dr. Ward will talk about, that allow us to, with a very high degree of precision, get digitized images of the prostate when it's out of the body, analyze those images to identify the types of cancer that are there, and then overlay those images with the pathology images with the images obtained before surgery, and then look for the correlation between changes on the imaging and changes in the tissue. And so this has allowed us to understand better what we're seeing on imaging like MRI, which is been used for a while now, but also start to explore new types of MRI, like sodium-based MRI, but also new types of imaging like PET-based imaging. And one of the reasons that PET imaging is quite attractive is because it uses the principle of a molecule that is designed to attach to prostate cancer cells and then light them up with a radioactive beacon in the body. And this can be helpful for characterizing cancer, not just in the prostate, but elsewhere in the body. So now you've got a tool that can give you information about the state of the cancer, where it started, but also, telling us if it's potentially spread. But we've been hampered by the lack of these sort of molecular or these chemical probes that are specific for prostate cancer. And so what's been developed here, but in collaboration with others in North America, has been investigating a series of new compounds. And the one we've been working with mostly is called 18F-DCF-PYL. And this is it doesn't look like much, but it actually has a very strong specificity for a part of prostate cancer cells called PSMA, which is a piece of protein sitting on the surface of the cell. And it'll glue onto it, and you can tag this molecule with a radioactive fluoride atom, which the PET scanner can pick up. So through our CIHR team and in collaboration with the Ontario Institute for Cancer Research, we've been part of a team Canada-wide that helped develop this particular tracer for clinical use. And we actually imaged the first man with this agent going back almost 5 years now. But this was really the start of evaluating a totally new imaging agent with this pipeline that we have. And so now what we could do is, in addition to getting our standard images, we could get these PET scan images and then start to analyze, okay, well, how does the pattern of uptake of the PET imaging agent in the prostate correlate with the presence of cancer, and really develop guidelines on how to interpret the PET images. So when you see a PET scan where the intensity is here, it's kind of got a blurry edge to it. Well, we can map out where the probability is of the cancer at different distances away from what we see on the PET scan. And that could help us plan, and say, a focal treatment, if we want to give a dose of radiation concentrated here, or some other type of focused treatment within the prostate, or even just helping the surgeon to understand that this is an area that they need to concentrate on when they're operating. And we've started to run clinical trials using this. This was a study where we used this imaging to help us better understand, with men who had prior radiation, where we suspected their cancers might be returning, better understand how those cancers were coming back, because we found that our conventional imaging with bone scans and CAT scans were not all that sensitive. But with the PET scanning, we could pick up many more men where the conventional imaging was negative, and it could tell us that they had an isolated recurrence in the prostate versus in a lymph node versus in a rib. And all of these situations need a different type of treatment. And so now we understand better for these men how best and what to treat them and what to offer them. And then this has been expanded province-wide. So our initial experience, coupled with some of the other centers collaborating with us, really created a strong business case with Cancer Care Ontario that this is an imaging technique that should be funded more broadly throughout the province. So we've been able to open a prospective study called PrEP, which provides enhanced access to men across the province who would benefit from this advanced imaging. And so now we're just analyzing the results from the first 1,500 men imaged on this study, and we enrolled these men over a very short period of time, over 18 months, and we're already on to our second cohort of 1,500 men. So we're going to gain tremendous information on how best to use this novel imaging through analyzing the results from this study. And we're continuing to build on that. So for example, the DCF-POIL isn't the only agent available. We have a newer agent, 1007, which is showing promise for being even more specific for prostate cancer and having some very attractive imaging qualities, which may actually allow us to implement this as the preferred agent in Ontario. And I'm happy to say we've just enrolled and imaged the first man in Canada, I believe, with PSMA 1007 today. And I was hoping to show a sample image, but they haven't got up onto the system yet. But I do have it under good authority that they had their first scans today. We are also looking at ways to analyze and utilize AI techniques to help us analyze these images. And then we're also going to be opening a study called Patron, which is really taking it to the next level and using this information to help design our treatments. So really moving this these imaging advances right to the point of care with the man. So with that, I'm going to stop sharing and let Erin take over and tell you a little bit more detail about some of the specific work we've been doing.
Guess I was muted. Now I'm not muted. Fantastic. Thank you, Glenn. Is my screen visible? Everybody see the red dot kind of moving around there?
Yep, you're good.
Great. Let me see if I can make you all a bit more visible to me here. Some Zoom tricks. Okay. Well, I want to echo Pam's comments and Glenn's comments. Thank you all very much for taking the time to spend with us this evening. I really wish we could be doing this sort of all together and we could show you the physical facilities and all that. But unfortunately, this isn't the year for that. So we'll have to do it virtually. So Glenn has given kind of a nice outline at a high level of a number of the initiatives we have going on. I'm going to be drilling in a little bit more deeply into one project that we have going on in the Veins Imaging Lab around prostate cancer. We have many different projects. We'll look at one that's quite relevant to a lot of what Glenn spoke about. And so this project is something that's been led by two of my PhD students. So my lab primarily consists of graduate students. Ryan Alfano and Chris Smith got together to try to answer the question of how can we sort of better target radiation treatment to cancer inside the prostate? Seeming like simple, high-level question. I'll also say that the work that you're going to see was done in close collaboration with Glenn, with Dr. Bauman, also with Dr. Hoover, who you're going to hear from next, and with Dr. Chin, who you're going to hear from later on today. So one of the things I love about working in prostate cancer research here in London is that we're not all working, each of us in our little silo. We do tend to work very much as a team approach with each investigator coming to the table with the expertise that they bring, and all of that put together allows us to solve the bigger problems. No one of us really has all the expertise needed to solve the big problems. So we work together, and as you can see in this example, the PhD students work together as well. So we're going to look at, there's two sort of elements here to the approach they took, and these are things that are going to be unfamiliar to you, and I'm going to drill in, and hopefully by the end you'll understand better what they mean. So the treatment approach they looked at was something called high dose rate brachytherapy, And the imaging approach was referred to by Glenn, this so-called PSMA PET imaging. And we're going to look at each of those and see how they put these together to try to improve targeted radiation treatment. This is something that they actually presented recently. Of course, it had to be virtual at an international meeting in Vancouver. It was quite well received, or would have been in Vancouver had we gone ahead. So first of all, for those of you who maybe aren't aware of what high dose rate brachytherapy is, I'm just going to give a little primer so that you can have some context and understand. And so this is a type of radiation therapy to the prostate. And the prostate here, we're seeing sort of a cutaway view of the man from the side. And there's the man's prostate right there. For reference, there's the bladder right there. And in brachytherapy, an ultrasound probe is inserted so that we can visualize, we can see the prostate. And once we can see the prostate, we can then insert these hollow needles that we call catheters. We insert a whole bunch of them on a grid that go into the prostate, and they're hollow, and you're only seeing kind of one column of them here, but actually there are several columns of them. So there's a grid of these. And once the catheters are inserted, we can introduce little seeds that slide in the catheters, and those seeds, they emit radiation. Wherever they're placed, they emit some radiation in a local region around where they're placed. And then as we slowly pull the seeds back out of the prostate, they deposit radiation at all different spots along the way in the prostate, which allows us to treat the prostate with a fairly high dose of radiation without delivering a whole lot of radiation to surrounding sensitive structures like the bladder and the rectum, and avoiding the urethra, areas that we really don't want to irradiate. And so the way that that's done is it's done with a stepper, which is a piece of equipment that can take the radiation seed and place it at specific spots within the prostate that you're seeing here with these green rectangles. So this is the top of the person, the bottom of the person, the back and the front, and the prostate outlined here in magenta. And so the idea is that the seed would be stopped at each of these points along one catheter for a specific amount of time that's going to deposit a specific amount of radiation. That process would be repeated for all of the different catheters. And it's all done under computer control with software that looks like this, where the different dwell times can be adjusted and so on to tune the deposit of radiation to the patient. And so in a nutshell, that's how high dose rate brachytherapy works. The issue is that we're guiding this under ultrasound guidance. And so under ultrasound, you can kind of outline the prostate for the most part. And these bright things that you see inside of the prostate are actually those catheters that I talked about. But you really have a hard time seeing where the cancer actually is. And so current state of the art with brachytherapy is to give the same amount of radiation everywhere in the prostate, irrespective of where that cancer actually is, because it's very difficult to see on ultrasound. And so what we're investigating, and what Chris and Ryan investigated, was this new imaging modality, this PSMA PET, that Glenn alluded to, its ability to sort of bind to a prostate cancer target and give us a nice bright target area that more than likely shows us where the dominant or maybe high-grade cancer is inside of the prostate. And here's an example where you can see this tissue image that was taken from the patient after they had the surgery, and you can see that there's actually quite good agreement between that hotspot on the PET scan and the actual location of the cancer for that particular patient. So we thought, could we do a study to see if we targeted prostate cancer and tried to put more radiation dose into that hotspot on the PET scan, would that really yield greater radiation to the real underlying cancer on histology? And when you look at this image, you think, well, obviously, I mean, it's right there. So if I boost it, I'm going to give more dose to this spot. This is kind of a very fairy tale type example where this really lines up very nicely. In reality, you see other deposition of cancer throughout the gland that may not be quite as visible on the PSMA PET. So we really wanted to set out to see if we target the PET, how well do we do in terms of targeting and hitting radiation to the true underlying cancer? To give you a sense of how this can be done. So here's an example where we've got the prostate contoured here. All little X's are the inserted catheters in the gland. And you can see in blue is the true histologic lesion from the tissue. In black is a contour that we got from the PSMA PET scan. And with a clinically standard plan, you can see that we're just trying to target the whole prostate. The radiation dose that's deposited, which is sort of more radiation in the redder zones, less radiation in the yellow and green zones, is not as hot in the area of the true tumor as it is over here in this example when we actually target the PSMA PET target. So just qualitatively, what we're doing here is we're increasing the amount of time that that radiation seed dwells at all those different dwell positions in these catheters that are near to this target in order to bring the dose up to that region. So that's just kind of what it looks like in pictures. But of course, we've got to do this by the numbers and see, how much of an increase do we get. Now, this graph's a little bit complicated. I'm not going to go into all of the details on it, but take it to mean that if we just look at the left-hand side of the graph here, that what we've got here is what kind of a dose of radiation do we get measured in units called grays when we target the whole gland versus what kind of a dose do we get to the histologic underlying cancer when we boost to the PET hot region on the PET scan. And what this sort of bar and the p-value is telling us is actually, yeah, these really are different. And we do, in fact, get a higher dose into the high-grade prostate cancer on the tissue when we target that PET scan. And we know from the kind of numbers we get out of here how much of a boost to expect. So that kind of gives us that confirmation that if we were to go ahead and start planning patients based on the PET scans, that we would see some return on that investment in terms of better targeting to the prostate. So I'm just going to wrap up here with a couple of high-level points. The first is just to illustrate at a high level kind of how we work. That's kind of really looking what we just saw. We really kind of zoomed in tightly on one project. But just to understand in the Baines Imaging Lab, the way that we work, everything we do starts with patient need. So what does a patient need? Does a patient need improved diagnosis, targeted treatment, or measurement of treatment response? So in this particular case, we were looking at a need for improving targeting of treatment. So we start with needs first and then build the right technologies to address those needs. So we are not a technology first lab. We are a needs first lab. We develop the tech to meet the needs. So in this particular case, we had some digital pathology involved, some fusion of the PET imaging to the histology involved, radiation therapy optimization involved. We've also got a huge branch of work going on in the AI and machine learning space that I don't really have time to talk about today, but we bring to bear whatever technologies we need. And then we target whichever disease sites we can with these platform technologies. So in this particular case, prostate cancer, but we're also looking in lung, central nervous, and pancreatic cancer in our group as well. And the thing we're really excited to be working on now, particularly around the AI space, an enabling factor for that is having very large databases of imaging, as you saw, pathology, as you saw, and so on, up to patient outcomes that inform the construction of these tools and models to help us to really make sure that they are functioning accurately and are sort of road ready to move forward. And we've got an initiative underway right now that's primarily donor supported that's going to enable us to really put this stage into higher gear and bring these larger curated databases together to really help us out. So we're quite excited about that. Last thing I'm going to say is around, I always see my lab as really having two primary products, and they're both important. One is the research that we do. That's important. The other is that our lab is a training ground for the next generation of scientists and engineers coming out. And so we're planting seeds with that training all over the world, where each of those individuals in their own way is contributing to moving forward toward better cancer control. And so for just to illustrate here over the sort of 10 years of our operation, this map is showing sort of the different points on the globe where our alumni, our MSc, PhD students and postdocs have landed and worked to establish their own operations and take that knowledge and continue to build. And we have people who go on to academic roles as medical physicists, actually helping with patient care. We have one off as scientists at National Institute of Health. This is a subset of 5, and then some others that go off into industry positions, one at Siemens, one at Reflection Medical. So it's really a diverse group that we train, and I'm very proud of these individuals who go on and are making their own mark, and in some cases they come back to us. So Dr. Matanen is actually a scientist in the other veins imaging research lab, and is growing her research program right here in London based on that training. And so I will end by again thanking very much. We have multiple funding sources that pay for all this, but most importantly is the funding that comes from donors. And I like to say, the funding that we get from these external agencies, that's the bulk of the funding that we use for our work. But this funding is very targeted in terms of how it can be used. It's very quite circumscribed and prescribed. What donor funding has done for us repeatedly over the last 10 years has enabled us to branch out in new directions and take risks, and those risks pay off. So we can de-risk good ideas and get early prototypes made to convince these external agencies to then put in hundreds of thousands to millions more dollars in to then take it to the next level. And so without the support of donors, I mean, you look at the name on my lab is a Baines Imaging Lab. Without the support of the Gerald C. Baines Foundation, we wouldn't exist. So I really want to thank all of you for the support that you have provided. It's absolutely vital to everything that we do. And I'll just end with a nice photo of my team in the before times when it was allowable to stand this close together without masks on. And I'll stop there, and happy to take any questions that you might have.
Amazing. Thank you, Dr. Bauman and Dr. Ward, for that great presentation. Now, if anybody has any questions, if you just raise your hand on your Zoom account. So you'll see that under the reactions on the bottom, it'll say raise hand, or if it's not there in the participant section. If anybody has any, just raise your hand and we'll call you on here. Or you can raise your physical hand as well. All right, I think Kirk, we'll unmute here, Kirk, and you can ask your first question. There you go, Kirk, go ahead.
Thank you both, Erin and Glenn. As always, you bring to the table huge amounts of information that we can easily understand. And each time I sit with you and I hear you, I learn something new. But the basics are there, and I see as your objective was to build a good team, and a team brings excellent results. I just wanted to thank you and commend you for all of your work and your dedication that goes on over there and around the world. So thank you.
Thanks, Kirk, for that very much, and thank you for your support. And I'm glad to hear that you felt that this was understandable. We're really trying to make this as accessible as we can. But if any of what we presented maybe got a little technical and we need some clarification, we're always happy to continue kind of simplifying, and we really want you to really learn and understand what we're doing.
Well, I think the advancement of your imaging is really the key here. I mean, each time it just seems to be stepping up and being able to understand and read that information with much more accuracy, and I believe that's kind of your direction. Is that not?
Yeah, absolutely. I think I sort of see this as a bit of it's kind of like a relay race where you've got kind of different players passing the baton, and so there's there are groups of people who are working on sort of development of novel imaging techniques, and that's not me. I didn't develop PSMA PET. That's not what I do, but they're kind of before me in the relay race. They develop these kind of novel imaging techniques, and then I live in the space where I take the baton from them and say, okay, how can I take that information with my team, fuse it with things like histopathology and outcomes and so on, to know how can we best use this in to address clinical needs. But then the people kind of come after me in the relay race are the clinicians and the medical physicists who know what the real needs are in the clinic. Without that guidance, I don't know where I need to be driving the bus. So I kind of see it as a relay race where I'm sort of sandwiched in between the people doing the basic imaging development and advancements, as you say, and the people who have the needs in the clinic, if that makes sense.
Yep, absolutely, absolutely. And you're doing a very good job of.
And I just would add that it also circles back because the technologies and techniques that Dr. Ward has developed is now feeding back into another iteration of next generation imaging. So one of the men imaged today with the 1007 is also getting sodium MRI imaging. So we're doing next generation MR imaging as well. And then we will use the pathology pipeline to validate that imaging. So it feeds in both directions. It feeds upstream and downstream. And I feel really lucky to be able to interact with people across the spectrum. And it's what's so exciting to me to see it moving back and forth like this.
And it's benefiting directly. I believe it's benefiting the patients in real time.
Yeah, I mean, we are able to offer men more information about their situation and help them make better decisions and give them better advice. And that really is gratifying to see.
Yep, super.
Awesome. Was there any other questions? Oh, we have it right here.
I see Shannon wants to ask a question, but I don't think that's Shannon.
All right, we're gonna ask to unmute you and you can go ahead and ask your question, okay? So I'm just gonna unmute you there. You'll see the unmute button there, sir. Awesome.
Yeah, I was just, can you hear me?
Yep, perfectly.
I was just wondering generally how the advances in imaging that you've so beautifully described and the other advances that you're working on, how has that changed over the last 10 years, the kind of treatment that is being offered?
So I think what you're going to see a little later in the presentation is some of the application of imaging to specific types of radiation treatments. That'll be a very nice demonstration. I think what's different for us now, just be very more specific to say some of the PET imaging, is that really the most sensitive test we had for many years to understand what was going on with prostate cancer was the PSA blood test, which tells us with great sensitivity what the cancer is doing, whether it's sort of in remission or whether it might be returning and such, but it has no spatial information. So you would end up with these very frustrating situations where men would have changes in their PSA, but you wouldn't have the imaging that was equally sensitive to be able to understand if you thought there might be a prostate cancer problem, where that might be. And so what the PET imaging has done is provided us with not a perfect tool, but a much more sensitive tool than what we've ever had to be able to inform men, okay, we see a change in your PSA, the PET imaging shows this, this is how we might act on it. We're still learning how best to use that imaging information and understand the limitations of it. But we're in a much better situation now, and that's a much nicer problem to have, to know how to use this new tool and to its best advantage than kind of working in the dark like we were 10 years ago.
Thank you.
Great. Is there any other questions before we move on to our next speakers? Oh, Ted, I'm gonna unmute you here and you can go ahead. So you'll see it pop up on your screen.
Yeah, I know this is sort of directed at prostate cancer and research and so on, but I'm curious to know what movement you're making on the side of pancreatic cancer.
So I guess I'll just speak to that briefly. And I think one of the things that I think you got the sense of was the importance of having team-based research to make advances. And I think one of the things that has really started to gain momentum in London is we've got a team of researchers focusing on pancreatic cancer now. And I think the focus of that research is a little bit different. It is more based on the biology of pancreatic cancer and looking more at things like genomic changes in pancreatic cancer and some of the fundamental biology behind pancreatic cancer, but also leveraging new imaging technologies to improve the care of pancreatic cancer patients. So, and running clinical trials for people with pancreatic cancer. So we, within the last couple of years, have really, and this has really been catapulted forward by the Baker family and their support of the Pancreatic Cancer Center. And so we are seeing a similar team of researchers coming together around that question. So that's very exciting for us too.
Maybe I can add to that a little bit. We've also got in Bain's imaging lab some work going on in pancreatic cancer. It's some new work. And it was a medical oncologist, Dr. Stephen Welch, and a radiologist, Dr. Zara Kassam, approached me with a really interesting problem where what they said was that one of the issues with pancreatic cancer is that there's no screening test for it. It tends to not really give you any symptoms until it's quite a ways along, and so by the time people are seen with it, it tends to have invaded major blood vessels that are passing through around the pancreas that make it very difficult or impossible to surgically remove when it's advanced that far along. And what they told me though is they said, well, more recently what's been discovered is that if you apply some radiation to the area, you apply some chemotherapy or a combination of both, that it's possible to make the cancer retreat just enough to make it possible for the surgeon to go in and operate and actually separate the pancreas from the vessels and with curative intent treatment that previously wasn't possible. However, they have a conundrum where once that treatment has been given to try to make the tumor retreat, the radiologist who's looking at the CT scan or the MRI scan has a very difficult judgment call to make, which is, has that cancer retreated enough to make it operable or not? And that's a key decision, because you don't want to send somebody for that invasive of an operation if it's not going to work. At the same time, if it could be resected, you definitely want to offer that to the patient. And so once sort of chemotherapy, radiation have been applied to that area, it becomes very, very difficult for the radiologist to tell if the changes surrounding the nearby blood vessels are actually still active cancer or if it's retreated enough. And so they've enlisted our help when we're building artificially intelligent tools based on machine learning to train the computer to help the radiologist see the very, very subtle signs in the images that would tell them whether or not that patient is resectable. So, I could report probably in a year or so as to what our results on that are. This is a relatively new project, but we're getting some good early signals out of this, and I'm quite excited about it. So I thought to add that into Glenn's answer as well.
Thank you.
Amazing. Is there any other questions? Awesome. Okay, that looks like everybody. So I'll bring Pam back on to introduce our next speakers. Pam?
Okay. Thank you, Justin. Thank you, Dr. Bauman and Dr. Ward. And next up, we have Dr. Lucas Mendez and Dr. Douglas Hoover. Dr. Lucas Mendez is a radiation oncologist, prostate brachytherapy lead at the London Regional Cancer Program. And Dr. Douglas Hoover is a medical physicist with 10 years of experience in brachytherapy. He's the physics lead for the prostate brachytherapy program and works closely with Dr. Mendez, the oncology lead. Dr. Hoover's research is focused on technological developments in both hardware and software, some of which will be implemented shortly in the upcoming clinical trials in prostate brachytherapy. They are coming to us today from right outside the brachytherapy suite. So Dr. Mendez and Dr. Hoover, over to you.
Okay. Hi, everyone. I believe you can hear me. My name is Lucas Mendez. I have Dr. Hoover here with us. So we're right outside the brachytherapy suite. And I think our strategy here will be a bit different than Dr. Bauman, Dr. Ward. We'll be showing more the brachytherapy technique and how things come along from a brachytherapy perspective, with a practical demonstration with the phantom that we have. I believe Dr. Ward's presentation made our life easier. We're just joking here because in part what we are trying to show, or our attempt is for you to understand how the brachytherapy takes place. I personally like to talk to my patients that have a confined prostate cancer about two different settings. One is patients that have a lowish risk prostate cancer, in which the chances of the cancer still be confined to the prostate are higher. And therefore, what makes most sense in this situation is to treat the prostate alone. But as the patient have a higher risk prostate cancer, driven more towards the higher spectrum of the disease, more disease is found inside the prostate or outside of the prostate to the pelvic lymph nodes or to the seminal vesicles, which are two organs that are attached to the prostate. Therefore, prostate brachytherapy has a role as a boost to external beam radiotherapy in the context of patients being treated with this treatment modality. So those are two treatment settings in which brachytherapy does apply, either as a monotherapy treatment schema or regimen, or as a boost to external radiation. The third setting that I like to mention is the salvage setting. So some patients, they do progress with prostate cancer recurrence inside the prostate. And that's where the PET PSMA is very helpful, because we don't want to subject that patient to some kind of treatment to the prostate if the cancer has escaped elsewhere in the body. But if the patient is proven to have prostate recurrence only in the prostate with no signs of disease elsewhere in the body, then some kind of active treatment to try to salvage this patient from the recurrence of the cancer makes sense. In this setting, prostate brachytherapy can also be used. And as other ablative therapies, as you'll see along in this the different presentations here today. So Dr. Hoover will be now speaking a little bit more about the different brachytherapy techniques, and then we'll be showing in a phantom some what we can see, what we can do, and how things go along.
Okay, thanks, Dr. Mendez. So I'm going to be telling you, I'll do a little bit of a show and tell, showing you some of the equipment we use and how we actually deliver this type of treatment. As Dr. Mendez mentioned, there's different risk categories for prostate cancer. So the low risk category, we tend to offer something called low dose rate brachytherapy. And in that setting, what we end up doing is we implant somewhere between 70 or 80 radioactive seeds into the prostate. And I've got, I don't know if you can see this on here, inside this vial, sorry, there's actually a bunch of decayed seeds. So these are no longer radioactive. And that's exactly what we'd implant in the prostate. And the way we do that is using special needles. These needles are LDR needles, and you probably won't see either, but these are actually hollow at both ends. So think of like a straw with a sharp end on it. If you can see here, there's actually a plunger on it. And so what we can do is you can load a bunch of seeds in a specific pattern in this needle, and you would implant it, as you'll see later in our demonstration how we do that. You'll implant it under image guidance, and we can actually push the seeds out, pull the needle back, push the seed out all the way along. So I said we had 70 to 80 seeds perhaps. That doesn't mean we actually have to poke you 70 or 80 times. We'll drop multiple seeds for each needle insert. Now this is actually an older style applicator that we use. We have newer methods of inserting these seeds. Sometimes they can be loose. Sometimes we can put them all together in a strand. We have a special applicator that we use here called the MIC applicator, and we can load all these seeds in a cartridge, and so you don't have to manually load them, and it makes it a little bit faster. So that one's LDR, and again, those seeds are going to stay in your prostate forever. When the patient leaves, they're going to be radioactive for a little while, up to 2 years, 20 months or so before we can no longer detect any radiation. And for the seeds that we use here, these iodine seeds,
they're radioactive for about, or their half-life is 60 days. So you can think of that as meaning after 60 days, half of your dose has been delivered. After another 60 days, and then we're up to half of half, which is now we're at 3/4 of your treatment is delivered until most of your dose is delivered. So it's a very slow and gradually, you're kind of beating down the cancer just continuously. So that's low dose rate. High dose rate, we have a similar type of needle, except now, as Dr. Ward explained, is actually closed at this end. So it's only open at one end. We'll again insert these under ultrasound guidance. And now we use a very, very high activity source that's actually going to go inside that needle, and it's attached to a long wire. You can see here. Again, this is not an actual radioactive source, but that can actually go into the needle, and it's going, as Dr. Ward explained, it's going to dwell at certain times, at certain positions. This is going to be within the needle. I'll come back a bit more, come back, and it will slow or deliver that radiation. And that only takes about 10 minutes to deliver. So if you compare and contrast 10 minutes of treatment versus multiple months, a very different modality. Of course, when we give high dose rate brachytherapy, in this setting, we also give a little bit of a boost with external beam radiation, so they get 2 different components of radiation. So at this point, we're going to do a little demonstration. I think Dr. Mendez is all scrubbed in and ready with our patient. Our patient, we have a technical term, we call it a phantom. It's basically, you can think of it as just a tissue mimicking piece of equipment that we use for quality assurance, for training, and for demonstrations like this. So I'm going to try to switch the view here, and I'll show you some of the ways that we use image guidance as well. So we got Dr. Mendez here.
Very good. So I can do a brief presentation of what we have right here. So we're set up in a way that we usually set up in the operative room. The patient will be under general anesthesia. Here, of course, we don't have a patient, but we have a phantom. And this little box here represents the prostate and the rectum. The area, the field of view that we really need to implant those seeds or the needles that are required. We have here a stepper that is connected to our table. The stepper has a transrectal ultrasound probe in position in a grid. So the transrectal ultrasound will give me an image of the prostate, through which I'll use this grid to find the position that I want to either drop the seeds or to place the catheter, the needles that I want, the hollow needles that I want for the HDR brachytherapy. Here we have our ultrasound display. So I'll start moving the prostate, I should say the transrectal ultrasound, to go inside what is representing the rectum. And as hopefully you'll be able to see, let me just, the image there, this white image represents the prostate, and the black dot in the middle is the urethra. So let's say I'm in the middle section of the prostate. You're seeing the prostate in a cross-sectional view, kind of looking from the bladder down. It's not a sagittal view, it's a transverse view here. So with this needle that is already loaded with one single seed, I'll represent how we usually do the LDR brachytherapy or the low dose rate deployment of the seed. So okay, so I'm bringing towards the apex of the prostate, and then I can see the white dot right here. And let's say this is a good position to drop the seed. So I'll change to what is called a sagittal view. So I can see the full length of my needle. So now we're looking the prostate sideways. We can see the full length of the needle. I'll pull it back a little bit, and I'll drop here. Let's say I find here is a good position to drop the seed. So you can see the seed being dropped right there and left inside the prostate. So I'd like to make an analogy suggesting that the seed is like a small candle and the prostate is a dark room. you need to position multiple small candles in this dark room to light it up the room. The same concept here. You need to position seeds throughout the prostate to build up a dose of treatment in which the prostate cancer that is within the prostate will hopefully die from this radiation that's being given off, and at the same time will preserve those to the urethra, which is our organ at risk. So from that, I hope you guys could see. I'm not sure how much you could actually see, but we are happy to redemonstrate that in the QA if the questions and answers if this was not a good representation. The last part of our conversation today that I would like to mention to you are the clinical trials that are currently going on in our service here. We have a trial that is integrating high dose rate brachytherapy in which no seeds are dropped inside the prostate. Only the radiation goes inside out in 10 minutes that Dr. Hoover described with something called hypofractionated radiotherapy. This is called the HOPE trial. So hypofractionated radiotherapy means less fractions of radiation, of course, with a higher dose of radiation per day. This is a randomized trial. We're reaching half of the accrual of the enrollment of the patients, comparing if patients receiving the standard of care, if they're doing as good as patients receiving this experimental treatment. We have 3 other trials that are in the phase of activation. One is called the Priapus study. The idea of the Priapus study is for patients that have prostate confined tumor. If we can drop those seeds in a way that we can treat nicely the tumor that we know based on the images that Dr. Bauman and Dr. Ward described, we have a good idea where the cancer is localized in the prostate. So the idea is to treat all this cancer, treat the whole prostate, but at the same time, spare erectile structures or structures related to the erectile function like the neurovascular bundle and the penile bulb. This is called the Priapus study. And we have another study called the Delight trial that we're planning to activate here, is already activated in Toronto. And the last one is something that'll hopefully come along with the pipe, the collaboration with Dr. Bauman, something that will be integrating on the salvage setting, brachytherapy with some sort of radioactive treatments like lutetium-177. Dr. Hoover, I believe you also would like to talk a little bit about the trials that you're leading right now.
Yeah, I'll talk about one in particular. Maybe you can come this way. So as I kind of mentioned, I'm interested in kind of using different technologies and incorporating those into some of the upcoming trials that we're working on. And one of the cool ones that I'll show you about now is something that makes use of power Doppler on the ultrasound. Uses sound waves to visualize interfaces with structures, but it can also be used to measure blood flow in patients. And the way it does that is using what's called the Doppler effect. A lot of you are probably familiar with that. If you hear, say, a car drives by and the horn is honking, you know that the pitch changes, whether it's coming with you, and then as it goes away from you, the sound goes lower. So that's called the Doppler effect. So ultrasound machines, all standard ultrasound machines can use that effect. And we want to try to use it to solve a clinical problem we have. And that problem is that sometimes in patients, we don't have good visualization of those needles. So you saw in this phantom that everything was nice and clear, but in the real world, we have calcifications in the prostate that can obscure those sound waves. We have what we call shadowing. So sound waves can't penetrate through a needle very well. So anything that's beyond this needle is going to be shadowed, and it makes it difficult for us to see those needles. And obviously we need to see them to kind of figure out where the dose goes and how to best treat those patients. So we have to figure out some way to use, this Doppler effect. But to do that, we need to vibrate these needles somehow in order to induce motion that can be picked up from the ultrasound machine. So together in a collaboration with Robotic Research Institute, we developed a Health Canada approved needle oscillator, we call it, that can just clip onto the end of the needle, give it a vibration, and we can use this Doppler signal to better visualize the needles. And I have on here a previous demonstration of what that looks like. So if you just try to pull it up. There we go. So I don't know if you can see that. That red color looks like it's on fire. That's the Doppler signal. So this needle is being shadowed by the needle in below it. You can see a little bit. But the idea is that if we put that vibration at the end of the needle, we can really clearly see the very tip, which you can see right there. That's the tip. And you can't quite make it out on just regular ultrasound. So that's something that a trial that we're ready to open up. It got halted by the pandemic, but now that we're opening back up, we're going to start doing a feasibility study in 5 patients, which should take no more than a couple months just to test it out in the real world. We've done all these tests in phantoms and quantified it, but really we need to see how it works in patients to see if it's going to be useful for us. So that's just one example of the technology that we're working on here.
All right, very good. I'll switch the view here. All right, so if we have any questions, we'd be happy to answer them.
Awesome. Thank you guys so much. If there's any questions, just feel free to raise your hand as we've done before as well, and we'll call on you here.
Sorry, I'm just trying to switch the camera view.
No problem. Is there any questions there that we're missing? None that I see there. Oh, Kirk. There you are, Kirk. I'll just unmute you there. Awesome.
Yeah, me again. And that was a very good presentation. I'm hoping that there's a little less talk and a little more action when you're doing it, so it's as short a time as possible. But thank you very much. And a good question I would be, how has COVID affected your research?
So I can answer that from the trials that I've been trying to lead. The HOPE trial is a trial, as I tried to mention, that is randomizing patients between the standard care and the higher risk setting. That is integration of HCR brachytherapy, or high dose rate brachytherapy, with 25 fractions of external radiation. This radiation is delivered to the lymph nodes in the prostate, in the pelvis, the prostate, and the seminal vesicles. So, in fact, this trial was not affected by the COVID pandemics because the idea of the trial is to reduce the number of fractions from 25 to 5. So that was actually seen as a favorable trial for the pandemics, since we're reducing 20 times the visits of the patient here to the cancer center.
Excellent. Excellent. Great answer. Thank you.
Amazing. Was there any other questions? All right. I'll welcome Pam back to introduce our next speakers.
Okay. Thank you, Justin and Dr. Hoover and Dr. Mendez. And next up, we have Dr. Ricardo Fernandez. Dr. Fernandez is a medical oncologist at the London Regional Cancer Program and an assistant professor within the Department of Oncology at Western University. Dr. Fernandez is also the Fellowship Program Director for Medical Oncology. He did his medical school and residency in Sao Paulo, Brazil, and subsequently completed an early phase clinical trial drug development fellowship within the oncology department at Oxford University in the United Kingdom, and then a clinical research fellowship in genitourinary malignancies and bone oncology at the University of Ottawa here in Canada. His research interests include genitourinary malignancies, early phase drug trials, immunotherapy, predictive biomarkers, and microbiome studies. Dr. Fernandez, over to you.
Thank you, Pam. Thank you for the nice introduction. I appreciate that. Good evening, everybody. Thanks for being here. I'd like to thank you for your time and attention this evening, and also for all your support. As being a junior staff, I haven't been here for a long time. I have my senior colleagues, but as being a junior staff, I do appreciate the importance of the donor into clinical research. So that's very important for sure. So I'd like to start saying that, well, first of all, as you can see, I'm broadcasting from, I don't know if you guys can see, but I'm broadcasting from the Bain Center. So this is a unit that has been designed to be a translational research unit. So basically, that's where we do our clinical trials, where the patients come for clinical trials. As you can see, it has only 3 chairs, so it's designed to be for less patients. They are separated by some space. There is the nurses station here for clinical trials in medical oncology. I'm a clinician, so we do need patients to be here for a while for the treatment infusion. There is need for a lot of blood work collection as well. So patients, it's a very nice space. We have the waiting room outside. So we are very happy with this space, and patients actually love coming here. So I'm broadcasting from here. Unfortunately, given the pandemic, we cannot see each other in person. So I thought to broadcast from here so you guys can have a bit of a piece of how it looks like. The other thing important to mention, and I believe you guys might know that, but the London Regional Cancer Center is a regional referral center for tertiary oncology cancer treatment for the whole region, for the whole southwestern Ontario region, with a catchment over 1.5 million people. So it's a lot of people we treat here. The genital eye disease site team consists of medical oncologists like myself. You may know other members, Dr. Ernest, Dr. Winquist, Dr. Potvin. We have the radiation oncologists. You've heard Dr. Bauman, Dr. Mendez. We have the nurses, the pharmacists, the social workers. So we have a big team to make that work. So it's about team. It's about like a group of people working together, right? We have expertise in clinical research, education, quality improvement, and also patient care, of course. And as Pam Taylor mentioned, the Division of Medical Oncology has a fellowship program since 2011. Now I'm the director, so now I'm willing to make them more sustainable. So we will have 2 GU fellows coming this July to work with us. So we're very excited about that. One is our trainee here, and the second one is a foreign trainee. So we're very excited about that. I'm gonna share my screen. Can I do that here? Okay. So I just wanted to, after this introduction, so as I don't have any, I always remember to show that because I don't have any relevant disclosures for this presentation. So I just wanted to show a couple of slides to you this evening in terms of the treatment, because I'm a chemotherapy drug doctor. That's the fancy term for medical oncology. So we deal with a lot of drug therapies. And in prostate cancer, I mean, I'm 41 only, so I have been a physician for over 10 years, but even though I haven't been practicing for a long time, but the prostate cancer treatment landscape has been evolving quite rapidly, which is amazing, which is fantastic for patients, of course. So this is a very brief summary here, because in prostate cancer, we have what we call hormonal sensitive disease in the left-handed side, which means patients, the cancer is still sensitive to hormonal therapy. And the hormonal therapy basically are medications that stop the body from producing testosterone, from producing the male hormones, and that kind of feeds the tumor. So by blocking that, we control the cancer. And then we have the CRPC, means castration-resistant prostate cancer. So once this hormonal therapy kind of doesn't work anymore alone to control the cancer, it becomes hormonal resistant or castration resistant. So as you can see here on all the treatment, all these names here, abiraterone, enzalutamide, radium-223, docetaxel. So these are all treatment options to treat patients with advanced prostate cancer. So as a medical oncologist, essentially what we see most of the time is patients with advanced prostate cancer, also called stage 4. So we treat these patients. The backbone of treatment is with ADT, which means androgen deprivation therapy. So we block the production of male hormones with medications, with hormonal injections, basically. But sometimes the hormonal injections on their own don't work anymore to control the cancer. And then we need other additional treatments. And these additional treatments are included here. So some fancy or hormonal pills. We have abiraterone, we have enzalutamide, we have chemotherapy, 2 chemotherapy agents listed here, docetaxel and cabazitaxel. We have radium-223, which is basically a radiopharmaceutical compound that binds into the bone spots of cancer, and it helps to relieve bone pain, but also helps to make people live longer. And then on the bottom here, we can see Sipuleucel-T. That's a immunotherapy type of treatment. So that is a drug that helps to train the immune system to fight against the cancer. So that drug is unfortunately not really available in Canada. It's being available in the States, and it's quite expensive. But this is just to give a brief summary of what treatment options we have available for patients with advanced prostate cancer. And this is like I said initially, it's been evolving, it's been changing. I've listed here some of the trials with different drugs that have been approved for prostate cancer, but the main change really is that we've been pushing systemic therapy options earlier in the course of the treatment to try to optimize the treatment and improve the long-term outcome. So it has been the changes that have happened lately is basically, we've been having some new phases of the cancer, not only hormonal sensitive and castration resistant, but we have other phases of the cancer listed here. I don't think it makes sense to go over everything, but it's just to give you a brief summary that the treatment has been evolving. We have more treatments. We've been using them earlier in the course, and that has been helping people to live longer, but also not only longer, but I always emphasize that to my patients. It's not about living longer. It's about living longer, but also with a good and decent quality of life. So without any pain, with being able to enjoy life. So we've been achieving that with quite success, I'm afraid. In terms of clinical trials, so Dr. Mendez mentioned, we have a very active clinical research unit. So I'm sitting at the Bain Center. Our clinical research unit is just outside of the center here. So it's very close by. We have a lot of people working there in terms of making these trials work. So this is a brief list of trials that we have open here in London. So as you can see here, we have some trials for high-risk prostate cancer with radiation, listed there with radiation and brachytherapy, as Dr. Mendez mentioned. We have some trials in first, second. So when I put there first line and second line means the upfront therapy that we give for advanced prostate cancer. Once these treatments fail to work, we call the subsequent line of therapy second line. So as you can see, we have few trials in first line, second line. We do have some trials to try to monitor the heart function of patients because most of these drugs can cause some long-term damage in the heart. So we have some trials looking at that as well. And then finally here, oligomets is just patients with fewer spots of cancer in the bones that we have radiation. But basically, really what we are trying to do here, these trials, some of them are industry-based trials, some of them are initiative of our researchers in Canada or locally as well. So it's a lot of it's lots going on, a lot of trials. It's not easy to be updated because it's a lot of novel agents, and we are combining different medications. We are using radiation therapy to try to help the systemic therapy as well. And I put this slide here just to emphasize because a lot of people don't really know how a clinical trial works, and there is a lot of aspects on the clinical trial, and that's why it's not only expensive but also time consuming and it does involve a lot of people. So we have the research coordinator people, the people who manage the paperwork, try to see patients, get blood work, get everything organized. We have, of course, the physician engagement and the patient engagement. We have the drug costs, with which most of the time are quite expensive. We have the Lawson Research Institute here with the contracts and the lawyers and that bureaucracy behind, which is also important. We have the consent process. So every time a patient goes on a trial, there is a written informed consent that we have, that the patient needs to, of course, read upon and sign that off. And then we have the ethical board's mission. We have our research ethical board, not only locally at the University of Western, but also provincially. We have the cost of the whole process. I didn't put the numbers here, but an average per patient is like 10 to 20,000 per patient in a drug trial, in a systemic therapy trial. We have the process of collecting all the data that we need, the research coordinators, but also data people. So these are all, I mean, I try to summarize most of the aspects of a clinical trial, which is quite, it could be quite busy for all of us. As I mentioned initially, and Pam did say that I'm now the fellowship director for medical oncology. I'm quite excited about it. I've done myself 2 fellows before, so I think it's very important. So basically, in the journey of a medical student, you finish your medical school, you do your residency, and then you do a subspecialty residency. For instance, I did medical oncology after internal medicine. And then after the residency, if you want to become more specialized in some specific disease site or in a specific topic, you do a fellowship, right? So we have the fellowship, a clinical research fellowship in GU malignancies. It's basically to try to provide clinical training with opportunities in research, education, quality improvement, and translation research. You've heard Dr. Ward, we have other scientists, so we have a lot of opportunities to collaborate with scientists and to do some translation research. We combine the clinical aspect with some sort of imaging, sometimes it's a blood work, sometimes it's a specific tool that we combine with the clinical aspect of the cancer. And this fellowship has been open actually since 2011. So this is not new. We are trying to make that more attractive and some pieces that we are trying to innovate there. We have some people, with myself, Dr. Winquist, Dr. Ernest, Dr. Potvin, the other medical oncologists, and we have, as I said, to make the translational component work, we have Dr. Malecki. He's one of the immunologists in the 4-4, one of these scientists. So I've been working with Dr. Malecki, essentially in Dr. Burton, in the microbiome. So we know that microbiome is basically our gut microbiota, the gut bacteria. There is a lot of data lately showing that the microbiome, the gut microbiota plays a key role on cancer, not only in any cancer. I've been actually doing a lot of research, a lot of trials in kidney cancer, where immunotherapy is a more established treatment option. In prostate cancer, is still early days. So I have a trial. It's not open yet, but I've got some funding. Thanks for the Catalyst grant and also for our local grant here. So in this trial, this is a prospective study. So we're gonna be getting patients and we're gonna look into these patients prospectively. We will be collecting blood and stool samples to assess what is the correlation between these oral fancy hormonal pills. I've mentioned a couple of them to you guys, abiraterone and enzalutamide. We have other oral hormonal therapies being used to treat advanced prostate cancer. So we're trying to see what is the association, what is the interaction between these oral drugs and the gastrointestinal microbiota in patients with prostate cancer. So basically, and a lot of the data shows that microbiome may help people to have less side effects depending on the profile of the gut microbiota, but may help to mitigate side effects. It may help to improve the efficacy of these treatments. So we're trying to understand better, because in prostate cancer is very early days. We don't know a lot. So this is a major collaboration within the Department of Oncology, myself and Dr. Winquist, the microbiology department with Dr. Jeremy Burton, and the immunology with Dr. Malecki. So we're very excited about it. We've published a paper last year with one of the drugs in the microbiome. But like I said, this is very early days. We're still trying to launch that. And I'm very excited to say that the microbiome role, we are basically a leading site here around the world, because we have the expertise of Dr. Burton, but also Dr. Silverman over the St. Joe's Hospital. So this is something that we are launching. This is very early days, as I said, but I think we can get a lot of knowledge from that specific tribe that we are going to launch, hopefully in the next few months. I think that's all I wanted to say. Like I said initially, I want to thank you guys for all the support you've been doing. I mean, the Banks Center has been basically, we have Kirk Banks there, but this is a real achievement from donation, from philanthropy, from the donors. And I think, moving forward for the future as being a junior staff, I think that's very important. And I hope for the next year, we can be in person here, all of us vaccinated, immunized, and do that amongst ourselves. I think the network, I'm happy to be here, but I would rather be in person with all of you. Thank you so much.
Amazing. Thank you so much. That was great. Is there any questions for Dr. Fernandez at all? If so, just raise your hand, or you can select it on Zoom itself as well. Checking. Don't think there's any questions there. Oh, 1 second. Awesome. Well, thank you so much. And I'll bring Pam back in here to for our next speaker.
Thank you, Ricardo. And up next, we have Dr. Chin. So Dr. Joseph Chin is a uro-oncologic surgeon at London Health Sciences Center and a professor of surgery at Western University who focuses on prostate cancer treatment with a special interest in new therapies. So Dr. Chin, over to you.
Yes, so thank you very much. I don't know if you can see me. I'm actually wearing my my earphones just so that I look like I'm actually doing a play-by-play for the Montreal Canadiens, but it seems to get better audio. So thank you everyone for staying around and joining us with this. I saw a few familiar faces there. Hi, Scott, Bob, Keith, Brian, John. I think I missed a few others as I quickly scroll through there. So I'm batting cleanup. So my topic is minimally invasive procedures. So I put in there the definition of minimally invasive procedures, which is any medical or surgical procedure which uses smaller incisions than a traditional open incision to gain access to and treat the diseased organ. Minimally invasive procedures aren't really new. They've been around probably 30, 40 years. Many of you are familiar with gallbladder surgery. It used to be a big incision, then there are two little incisions that are being used to take out gallbladders through laparoscopic surgery. So that's one of the earlier examples of minimally invasive surgeries. There's coronary artery. Some people are familiar with arterial stenting or dilation of the coronary vessels for the heart. Here's a knee. So knee surgery, arthroscopy is another example. Some of you probably have undergone that. Endovascular aneurysm repair is a very, very important way and very beneficial way of treating a very serious life-threatening condition now with so-called minimally invasive approaches. So moving on to a urologic side, which I'm more familiar with, of course, from the kidney, we get kidney surgery, kidney stones, laparoscopic surgery, take out the kidneys or kidney tumors, kidney stones. There are different ways. This is one form of really very, very minimally invasive. Is a non-invasive altogether is an external energy going in through the body with shock waves and hitting the kidney stones, targeting the kidney stones, and the kidney stones break up into little pieces, and then they pass down the ureter, the tube going down towards the bladder. And another way we deal with kidney stones is go through the urinary system, through the channel into the bladder and up the ureter, and either break it up with a little jackhammer, or we take out little stones with little baskets like that. Now, moving another way, talking mostly about cancer now, say kidney cancers, we can do So this is the abdomen. The person has a couple of needles going in through the abdomen. This is guided through either an ultrasound examination or through CT scan. And then this is the inside view of the kidney inside the abdomen. We can actually see these probes are into the kidney. And then when freezing actually occurs, it actually freezes the tumor. So this is going to lead me to talk about prostates, of course. So we've been really lucky to have with us colleagues who do imaging research, as Dr. Erin Ward, as you heard earlier, and others. So advanced X-ray imaging techniques are really crucial for minimally invasive procedures, surgical procedures. As you can see here, this is a timeline from 1980s to year 2020. Over a 40-year period, there are many different developments going from CT scan to transrectal ultrasound, two-dimensional ultrasound, three-dimensional ultrasound, MRI, 1.5 Tesla, and then now 3 Tesla, and then different more sophisticated ways to do CT scans and MRI, multi-parametric MR, and PET scan, and now we do fusion of different images. As Dr. Bauman talked about it earlier a bit. The 7 Tesla MR, so obviously these are much more sophisticated, and Dr. Bauman talked about the PSMA PET scan and so forth. So with that, with these developments, we've been able to actually take advantage of that and use those to help us with treatment for prostate cancer using different ablative techniques, such as cryo surgery, brachytherapy that Dr. Mendez has already talked about earlier, HIFU, high intensity focused ultrasound, lasers, different types of lasers. I'll talk briefly about this one. It's called irreversible electroporation, a mouthful, but I'll explain it briefly. And then this is a very exciting technique that we've been involved with as well as other things. So over the years, a lot's been happening. I'm just going to update you briefly. So radical prostatectomy, for one thing, because I'm a surgeon, so I take out prostates. In addition to the minimally invasive procedures, we can do more so-called maximally invasive surgeries, like taking out the whole prostate through an incision, such as this, or we can do them with robotically, like this, with little incision. Now you can argue you add up 4 or 5 different incisions, it may be about the same as this one, but there are different approaches. With robotic surgery that you're all familiar with now. This was me back in, actually, I actually had a date there. It didn't show up here. It's 2004. Okay. April 2004 is when this happened, when we did the first one in Canada, first robotic prostatectomy in Canada. I had a proctor, fellow from California, came out, and I've been down working with him for a little while, and then he came out and helped us do the first case. Just to show you, this is some of you may have seen this in previous presentations if you've been with this tour before. These are number of robotic units that of course, in the United States, as you can see, or this number of years, 2005, 2006, 2007, the number of new installations of robot units in the country. So it looked like raindrops, you can see, all over the place, and up to about 2013. I think that's the end there. And in contrast, this is Canada, you see. And here, London, right down there. And we actually had the first unit in the country. Now they're a smattering, again, it has to be updated. There are probably about 20, 25 units across the country now, but we were the first ones in the country. And we still actually have 3 units. And some of the donations from the foundation, through the foundation, from donors like yourself, have gotten to help with updating and upgrading the robots here in the country. This is the first publication that we did back quite a while ago, 2017, I think. Initial experience with my colleagues, Dr. Patrick Luke and Dr. Stephen Powler. And actually, there's an editorial on that, and the editorial says, early birds gets the worm, ? Or are fools diving in ? So you can answer that. But obviously, robots have taken on, and it's being used very extensively now. So for surgery, I won't go into too much more about that, but I'll talk more about the other procedures, the so-called minimally invasive salvage procedures, which are procedures done after patients, if they had radiation and radiation didn't completely kill all the cancer. So there are a couple of things, the cryosurgery, HIFU, and I'll go through each one very briefly. Cryosurgery is freezing, the freezing. It could be the prostate, it could be kidney or whatever. This was 1992 New York Times. There was an article that said if fire fails, so fire was heating it with radiation or other energies, they then try ice. So ice. So in fact, ice, cryosurgery, ice actually has been used a long time before then, but there've been some improvement with these different techniques with different cryogenic technologies. The percutaneous instrument, meaning the instruments were put through the skin, and then transrectal ultrasound. Transrectal ultrasound meaning, as this name tells you, through the rectum. So a probe goes in the rectum and gives us a really good image of the prostate. This was back then was revolutionary. This, some of you may have seen that. This is a special chair, 1974. So this was called the throne because people actually sit on it. And you can see there's a probe here, which makes you a little uncomfortable as I speak. And this probe actually then rotates and actually gives ultrasound images. So this was actually the first ultrasound, transrectal ultrasound machine. We don't use this anymore, thankfully. So that's helps with placement of the probes, of the instruments and so forth. And this is, again, cryosurgery. I won't go into details, but different machines going from bigger machines now, there are smaller machines. Years ago, we used to actually make an incision and then put the probe to literally touch the prostate with some freezing material, and now is much more sophisticated. And here, just to show you some key collaborators of our initial cryosurgery program, Erin Fenster, who's biophysicist extraordinaire, my previous colleague, Donald Downey, radiologist, and you can see here, Paul Martin, former prime minister, just touring the Robarts Center. And this was when we announced the local procedure. This was years, again, 1995, so 20 some years ago now. So this, again, cryosurgery is still being perfected. We've had extensive experience with it. The probes are important, where we put the probes to in terms of freezing. And again, as I said, there are multiple improvements over the years from first generation to third generation now, much more sophisticated technology with that. I just want to jump on as time goes. HIFU is high intensity focused ultrasound. Again, that started way back in the 1950s with different technologies for different parts of the body. The brain, they were treating the brain. So if you're treating the brain, obviously it has to be extremely precise. You don't want to miss even a millimeter. You'll be hitting something else that would be a lifelong result that wouldn't be pleasant. So for the brain and then thyroid gland and then the eye for glaucoma treatment. So again, it needs extreme precision. So the prostate then was used in the 1980s, and we've been doing it now for a while. Again, these were early machines. You can see 1972. The technology of HIFU is high intensity focused ultrasound. Everybody's familiar with ultrasound. This is if one goes for an ultrasound of the gallbladder, ultrasound of a baby, a pregnant female having a baby. These are ultrasound. You get an image, but when you focus all those ultrasound rays or bits of energy all focused into one area, it all heats up and it adds up. So this is the spot where we actually the energy can kill tissue, can kill cells. So this is, it doesn't look like it much, but in fact, this is the where the action is a so-called therapy transducer. Actually, when you flip it around, the other side is an imaging transducer. So this is how we do that. The ultrasound, again, the probe goes into the rectum, and the treatment, as well as the ultrasound I mentioned earlier, the transrectal ultrasound. So the treatment then and hits the prostate. So again, just to call a picture. So it just shows the energy, where is focuses. The red is the hottest, and here is the coldest. So it's kind of like this, just to show the point of how precise it is. I won't bore you with details, but 1 millimeter difference is where the temperature changes from 95 or 100 degrees down to 30 degrees. So basically, room temperature or body temperature, I guess. So very, very precise. This is just a little piece of turkey meat, actually, but you can see this is heated, and right in between you can spare the area, and it heats again. So this just shows a time frame. Again, we can split the the treatment and control it in a split second, so you can stop the treatment, and so be very, very precise. Just a couple of different machines. There's a bigger machine, there's a smaller machine. We happen to have this one. Again, a lot of this requires a lot of expenses, a lot of money. And over the years, our program has been supported by the foundation. So when I say precision, very precise treatment with HIFU, that leads us to focal therapy, and that's where we can actually treat an area of the prostate without treating, say, the whole prostate, or if we want to focus on, say, in one little area and spare the rest of the prostate. If we know that it is not cancerous and only this part is cancerous, we can maybe focus on that. Now, it sounds easier than it actually is. Is in fact a lot of other research and a lot of other challenges are there that we have to still overcome, and that's with the help of our imaging colleagues and so forth. So we want to get back and do biopsies of the area to prove that we actually have successfully treated the area. So as I say, there are lots of issues there. I'll just move on quickly. This is an interesting thing called TUCAT. TUCAT, those of you who speak Hebrew, that means warmth of light. So what does that mean? Well, the warmth of light, when Moses saw the burning bush, there's a study. This is actually heat that we can generate by putting a material, this chemical, into the body, and it basically latches onto certain cells, cancer cells, more than it goes on to normal cells. So this material then is concentrated in the cells, and then a light is actually shown, a laser light is shown on there, and it actually, then these cells literally light up with the fire, so like a burning bush. So that's actually is the technique. There have been many versions of this TUCAT, the compound now, and this is just a mouse, for example, showing that a mouse tumor. We actually created this tumor in a mouse, and then I'm sorry, this is a rat. Sorry, I said a mouse. Is a rat. But they actually then the heat is, you can see the heat map basically after TUCAT treatment and laser treatment, and then this is after the treatment, and so the tumor has been basically ablated, and you see the rest of the animal is the other rest of the tissue is spared. Again, this just shows the level of where is most active along the light spectrum. This technically is what's been doing, how we do this TUCAT. Again, is pretty involved in lots of laser fibers and so forth. This is the bottom part between the scrotum and the rectal area. So these are actually directly going straight into the prostate, and then as you can see, the room is dark and so forth. So we have to do all kinds of other adjustments to do this type of treatment. So as you can see, it's a pretty labor intense. So I've basically talked about this cryo, HIFU, and a bit of this is photodynamic therapy. You've already heard about brachytherapy. A couple of other things. This one very briefly, just to talk about that. Sorry, laser first. A couple of just pictures. Again, you can insert a laser right into the tumor. Again, this is kind of focal treatment we can actually now do instead of the rest of the prostate. Again, you can see that this involves a lot of precise imaging. So we rely on imaging colleagues to help us with that. And that's where the collaboration is. Now, so this thing called irreversible electroporation, as I say, is a mouthful. Basically, is a fairly simple thing with electric currents actually hitting, actually poking into the prostate, and then basically we turn up the voltage, and the electricity then makes holes in cells, and then the cells actually die. Basically, we're actually not doing this at the moment, but we have been looking into that. But just to complete the kind of the spectrum for the whole discussion here. So finally, this technique here I'm most excited about is the MR guided transurethral ultrasound ablation. They call it TULSA, TULSA, TULSA. And so it's done in an MRI machine. This is a very special probe that's developed actually in Canada. It was in the Sunnybrook labs, but they involved us very early in the start. We did some of the doc studies, and then we did the first clinical trial here with Robarts in the Robarts facilities, the MRI machine. So what it does is it allows us to, and I'll just show you the video, to put this probe in, and it actually exerts energy from within the urethra. So hopefully this runs. So the person is inside the MRI machine, is asleep, and we're taking pictures. There are 10 or 12 slices. Each one of these is a slice of the prostate. So different shapes. This slice is different near the tip of the prostate. Whoops, sorry. Sorry. Go again. I just won't touch it. The different slices and different shape. And I would, or the radiologist would help me. We'll outline the prostate as to where we need to treat. And then this probe rotates and actually shoots energy, kind of like a plane of energy that rotates 360 degrees and treats the prostate from within the urethra. The advantage there is that the heat comes from within the urethra, so the rest of the prostate surrounding tissue, the tissue surrounding the prostate, I should say, has very minimal damage to the surrounding tissue all around. So there's the rectum is behind the urethra is in the middle, of course. The nerves that control erections are running along the side, so they can be spared as well. And this requires a lot of collaboration and coordination, as you can see. And I listed them here, between surgery, radiology, radiation oncology, anesthesia. Of course, they have to put the patients to sleep and inside an MRI machine. We have the special nurses, computer scientists, MR technology people, and of course our clinical trials personnel, and so a lot of collaborative work goes into this treatment. So this guy obviously has had it. He looks pretty happy. I think it was number 4 in the world that was treated with this. And as you can see here, this is the same picture. Where is this? This is actually downtown Toronto, on the junction of College Street and University Avenue, right? The Mars building. This is the outside of the Mars building when they were doing some construction. So they had some panels there and the pictures. So there it is there. There's another picture. So this is actually, you can see here, this is University Avenue going down this way. And there's another picture with showing me putting the probes in. So this has drawn a lot of attention with this technique, and we've done some publications already. So the first trial was actually only 30 patients in collaboration between us and in Germany and a few patients in the US. And I actually made the front page of these urology journal. You can see these pictures are from our treatments. And not only can we do the whole prostate, we can now treat just part of the prostate. We can target it. So that's exciting as well. And then I mentioned earlier, salvage, meaning after radiation treatment. So we're planning to do a study with Dr. Bauman and his group, and with salvage after radiotherapy. and even more exciting, there's another trial coming up that we're involving ourselves in the US and a group in Finland with TULSA, with this technology transducer ultrasound ablation with radical prostatectomy, comparing one to the other kind of head on. So one person we randomized to this and another person we randomized to that to minimize any bias. And in the end, we'll try and see if this is as good as, or could be even better than radical prostatectomy. So again, there are lots of other publications already from us, the Scandinavian Journal who talked about this, and then European Radiology and some other American journal. So with all of this, I just want to highlight some of the other issues very quickly. Is obviously we generate a fair bit of data and some attention. I already alluded to some of the international activities. So a lot of international collaboration. This is, for example, this is with the group with MD Anderson with our Cryo Surgery. They have a very similar program going on same time we had. So we combine our data and are analyzing them and publishing the results. And this with the Mayo Clinic, same thing. Theirs was, we did their radical prostatectomy patients with our cryosurgery patients. This is after radiation failure, comparing the two groups. This is with Memorial Sloan Kettering. Again, this compares different technology, different techniques. So obviously there's been international collaboration, as I mentioned, and I also should mention that it also allows us to train a lot of people. We've attracted a lot of fellows from around the world, and they've been learning all these different techniques, involved in any of these programs. So just to summarize, time is up pretty well. That minimally invasive therapies are obviously very promising and have been very beneficial for many clinical situations. There's significant benefits to a lot of patients, but obviously they have to be chosen, to be carefully selected. It involves a lot of collaboration, local, national, and international, from the study that we've been doing. And of course, thanks to the foundation, thanks to the donors, such as yourselves, with the resources that have been provided. It does obviously consume and involves a lot of time, a lot of effort and resources. And as mentioned, offers training to future physicians and surgeons. And not to be outdone by Dr. Erin Ward, this is our picture of the fellows that have been that have been trained here, and they're all over the world, as you can see, and basically they're and I would like to say they're in every continent except Antarctica. So with that, I think I'll stop, and I'm glad to entertain any questions. Thank you very much.
Amazing. Thank you, Dr. Chin. So just as we've done before, if there's any questions for Dr. Chin, feel free to raise your hand. Don't see any there, I don't think. Ted, did you have a question?
Oh, yes, Ted, sorry, I forgot to mention your name. I did see you there earlier.
Awesome. Well, it doesn't look like there is any questions here, so I'll bring Pam in to conclude the tour. Thank you, Dr. Chin.
Thank you.
Oh, Pam, I think you're muted there.
Thank you. Technological difficulties. So thank you, Justin. Thank you, Dr. Chin. And I just want to start by first of all, thanking all of the clinician researchers who joined us this evening, Dr. Bauman, Dr. Ward, Dr. Hoover, Dr. Mendez, Dr. Fernandez, and Dr. Chin. Thank you all so much for taking the time to share your research, the new things that are happening, how training helps with the next generation, just a whole lot. We are so very blessed to have you all here in London, collaborating nationally, internationally, and helping change prostate cancer. And then to everybody else, I'm so sorry we can't be together in person, because I know a lot of you as well, but a huge thank you for taking a couple of hours out of your Tuesday night Thank you for joining us. We all hope actually that you enjoyed this, that you found it interesting, got a chance to see exactly how donor support makes a difference and all of the really incredible work happening here in London. So hopefully the next time we will see everyone in person, and COVID tours down. But everybody take good care, stay safe. Thank you so much, and have a great night.